Okay, let's get into this. I'm looking at the desk right now, and wow,
It's quite the stack, isn't it?
it's a bit intimidating. We've got Katie Tripathi, we've got Morgan and Mikhail, Miller's Anesthesia.
The usual suspects.
Yes.
The Oxford Handbook, some ICU protocols.
It's a mountain of paper.
It is a mountain, but, it's the mountain you have to climb if you want that MD.
That's very
And
true.
if you're listening to this, you know exactly why you're here. You're probably staring down the barrel of the Gujarat University MD anesthesiology exams.
Exactly. And that stack of books, it feels like the barrier between you and that degree.
It can feel that way.
So for everyone listening, welcome. Welcome to this special deep dive. We're going to treat this session like a dedicated study session just for your exams.
That's the idea.
I'm your enthusiastic, maybe slightly overwhelmed study buddy, just trying to make sense of it all.
And I'm here to help you, and everyone listening, filter out the noise. Think of me as your senior faculty mentor. I've seen the exam papers, I've sat on the Viva panels.
So you know what they're looking for.
I know what we're looking for.
That is exactly what we need. So our mission today is to take all these heavy textbooks and basically turn them into a high-yield audio guide.
Right. We're not just reading from the book. We're extracting the gold.
And the topic for today is, it's the absolute bread and butter of our specialty.
It really is. We are covering adrenaline or epinephrine and isoprenaline.
Okay?
We're going to dig into the pharmacology, the detailed mechanism of action, and most importantly, the applications in anesthesia and the ICU.
And just a quick note to you, the listener. We know you're prepping. You might be driving to the hospital. You might be in the residence room on a break. We're not just doing this so you can pass the exam. We're doing this because these are life-saving drugs. You absolutely have to master them.
Precisely. In an emergency, in a code blue, you don't have time to look up a dose or a receptor profile.
Yeah.
It has to be a reflex. It needs to be hardwired into your brain.
All right. Let's do it. Let's dive into Part A, Basic Pharmacology. We need to frame this for the exam.
Yep.
So if I get a question on, say, sympathomimetics, or I'm in a Viva, and the professor says, start with the basics, where do I even begin?
You start with the chemistry. I know it sounds a bit dry, but it's the foundation for everything else.
Okay.
If you're writing a theory answer or you're standing there in front of an examiner, you need to define what a catecholamine actually is.
Right. It's not just a word we throw around.
No, it's a specific chemical structure. Both Tripathi and Morgan and Mikhail are really clear on this. You need to visualize it.
Okay, I'm trying.
You have a benzene ring. On that ring are two hydroxyl groups at the 3 and 4 positions. That specific arrangement is called the catechol nucleus.
The catechol nucleus, right.
And then attached to that, you have an amine side chain.
So benzene ring, 2 hydroxyls, amine side chain, that's the formula.
That is the magic formula.
Yeah.
And from there, you need to make a distinction. You have to separate what our body makes versus what we draw from a vial.
Okay, so endogenous versus synthetic.
Exactly. The endogenous ones are the naturally occurring catecholamines. That's your adrenaline, your noradrenaline, and dopamine.
The big 3.
Right. Then you have the synthetic sympathomimetics. These are drugs like isoprenaline, dobutamine. They mimic that catechol structure to hit the receptors.
But they've been tweaked in the lab.
They've been tweaked. They've been designed to have a preference for certain receptors over others.
Okay. What about the synthesis pathway? I always get a little mixed up on the order of things here. How much detail do we really need?
For a high-yield answer, you just need the flow. It's a cascade, a production line. It all starts with the amino acid tyrosine.
Tyrosine. Got it.
And the pathway is pretty straightforward. Tyrosine becomes dopa. Dopa becomes dopamine. Dopamine becomes norepinephrine.
And then finally?
Norepinephrine is methylated to become epinephrine or adrenaline.
Tyrosine, dopa, dopamine, norepinephrine, epinephrine.
Okay. And if you really want to impress the examiner, you mentioned the rate-limiting enzyme.
The bottleneck.
It's the bottleneck of the whole process. It's tyrosine hydroxylase. That enzyme determines how fast the factory can run.
Tyrosine hydroxylase. Okay, noted. Why is this topic, these 2 drugs in particular, so important for the Gujarat University exams?
Because they are the absolute cornerstone of hemodynamic management. You are guaranteed to see questions on them, probably in one of 3 formats.
Okay, what are they?
First, you've got the big one, the dreaded long question, a full 20 marker on the pharmacology of adrenaline and its clinical uses. You can't fake a 20 marker, you need real depth.
Right.
Second, short notes. They often ask about, say, Isoprenaline in modern practice, or the management of anaphylaxis.
And the third one?
The viva voce. This is where they really test you. They'll hand you a pen and paper.
Oh, no.
And they'll say, draw me the dose-response curve, or explain the G protein signaling pathway. And believe me, if you can't draw it, you can't pass it.
Well, that's a perfect, if slightly terrifying, segue into our next section, adrenergic receptor physiology. This is marked as very high yield.
It is the absolute foundation. You cannot possibly understand how these drugs work if you don't understand their targets.
And the targets are the adrenergic receptors.
Alpha and beta. And they are all a type of receptor called a G protein coupled receptor, a GPCR.
I remember reading about the structure. They described it as serpentine.
That's a great visual. It's a protein that snakes its way across the cell membrane 7 times.
Okay.
When a drug like adrenaline binds to the outside, it triggers a change which activates a G protein on the inside. But, and this is the whole key, the type of G protein it activates determines the effect.
Okay, let's break that down then. Let's start with the alphas, alpha 1. How do we keep the mechanism straight?
Okay, there's a good mnemonic for the G proteins, QISS. QISS. The first one, alpha 1, is linked to the GQ protein. So Q, I want you to think Q for squeeze.
I like that. Q for squeeze. So what's happening inside the cell?
When GQ gets activated, it turns on an enzyme called phospholipase C. This enzyme then splits a membrane lipid into 2 second messengers, IP3 and DG. IP3 is the important one here. It travels to the cell's calcium store, the sarcoplasmic reticulum, and tells it to release calcium.
And in any muscle cell, Physiology 101, calcium means contraction.
Exactly. So where do we find alpha-1 receptors? In vascular smooth muscle. You hit them, calcium floods the cell, and you get vasoconstriction. Squeeze.
Where else?
Also in the radial muscle of the iris, so it causes mydriasis, pupil dilation, and it constricts the sphincters in the GI and GU tracts.
So alpha 1 is the squeeze receptor. Okay, what about alpha 2? This one always feels a bit weird and counterintuitive to me.
Yeah, alpha 2 is the odd one out. In our QISS mnemonic, it's the I. It's linked to the G protein.
I for inhibitory.
I for inhibitory, exactly. It does the opposite of what most other receptors do. It inhibits an enzyme called adenyl cyclase.
Which means you get less CAM-AMP, the second messenger.
Correct. You get a decrease in cyclic AMP inside the cell, but its location is what makes it make sense. Alpha-2 receptors are primarily presynaptic. They sit on the nerve terminal itself.
Ah, so it's not on the muscle, it's on the nerve that's firing.
Precisely. Think of it as a negative feedback loop. When a nerve releases norepinephrine, some of it circles back and hits the alpha-2 receptor on that same nerve.
And that tells the nerve.
It tells the nerve, okay, that's enough. We have plenty of norepinephrine in the synapse. Stop releasing more. It's a break.
Which is why alpha-2 agonists like dexmedetomidine cause sedation. They're hitting the brakes on the whole system.
Exactly right. As Miller points out, they cause sedation and analgesia because they're turning down the gain on the sympathetic nervous system.
That really clarifies it. Alpha 1 is the muscle squeeze. Alpha 2 is the neural brake.
Oh.
Okay, let's go to the betas. Beta 1 and beta 2.
All right, moving down our QISS mnemonic. The betas are the 2 S's. They are linked to the G's protein, S for stimulatory.
Okay, so the opposite of alpha 2.
Exactly. They stimulate adenyl cyclase. This leads to an increase in KMP. That KMP then activates another enzyme called protein kinase A, which goes on to a bunch of things, including opening calcium channels.
Wait a minute. If they both increase KMP and bring in more calcium, why do they have opposite effects in different tissues? Beta 1 makes the heart pump harder, but beta 2 makes the lungs relax.
That is the million-dollar question.
Yeah.
And it's the beauty of tissue-specific signaling pathways.
Okay.
In the heart, which is all about beta 1, that calcium influx directly drives contraction. More calcium, stronger squeeze. Simple.
Right.
But in smooth muscle, like your bronchi, which is beta 2 territory, the downstream pathway is different. The increased AMP and pKa actually lead to the phosphorylation of an enzyme called myosin light chain kinase.
And that does what?
It inactivates it. And if you inactivate that enzyme, you prevent the muscle from contracting, so you get relaxation.
Wow. So the same second messenger, SANCMP, causes contraction in one place and relaxation in another, just depending on the machinery in the cell.
That's exact.
Okay, so let's focus on beta 1 first, location and effect.
Simple rule. You have one heart, so beta 1. It's postsynaptic, mostly in the heart. Stimulation gives you 3 things you have to list on the exam.
The 3 tropes.
The 3 tropes. Positive chronotropy, which is increased heart rate. Positive venotropy, increased contractility. And positive dermotropy, which is increased conduction velocity through the heart.
Rate, squeeze, speed.
Perfect.
Is it found anywhere else important?
Yes. And this is an exam favorite. It's in the justiculamerular cells of the kidney.
Ah, the JGA.
Right. Stimulation there triggers the release of renin, which kicks off the whole renin-angiotensin-aldosterone system.
Okay. And beta-2.
You have two lungs, so beta-2. But it's not just the lungs. It's in the smooth muscle of blood vessels, especially in skeletal muscle, and the uterus.
And stimulation causes relaxation across the board.
Yes. So you get bronchodilation, vasodilation, and uterine relaxation, which we call dialysis.
And what about the metabolic effects?
Oh, yes. Beta-2 also stimulates glycogenolysis in the liver, so it breaks down glycogen to release glucose, and it triggers insulin release from the pancreas.
So why is this whole concept of selectivity so critical for us in practice?
Oh, it's everything. Think about your patient with asthma who also has high blood pressure.
Okay.
You want to give them a beta blocker for their heart. But if you give them a non-selective one, like Propranolol, it's going to block beta-1 in the heart, which is good.
But it's also going to block beta-2 in the lungs.
And that could be lethal. You'd be preventing their airways from dilating. You could trigger a severe bronchospasm. Choosing a selective beta-1 blocker, like metoprolol, saves lives. That's why selectivity matters.
That's a solid groundwork. Chemistry receptors.
Okay, let's tackle the star of the show. Part B, adrenaline, or epinephrine.
Adrenaline is the prototype. It's the main endogenous catecholamine. It's secreted by the adrenal medulla.
And it's mostly adrenaline that comes out, right?
Yeah, Guyton tells us the adrenal medulla secretes about 80% epinephrine and only about 20% norepinephrine. And how would you describe it in a single phrase? It seems to do a bit of everything.
It's a broad-spectrum agonist, a non-selective agonist. It doesn't pick sides. It hits alpha-1, alpha-2, beta-1, and beta-2. It's the ultimate fight-or-flight hormone. It's the drug of resuscitation.
And I think this is where it gets really interesting for the exam. It doesn't just do the same thing at every single dose. This is the dose-dependent switch.
This is the absolute core concept for the mechanism of action. You must know this inside and out for the Viva. Adrenaline acts differently depending on how much you give.
Okay, walk us through the levels. Let's start low, a tiny infusion.
At a very low dose, we're talking 0.01 to maybe 0.02 micrograms per kilogram per minute. The effects are predominantly beta-2.
Beta-2, so that's relaxation, vasodilation.
Exactly. So what you'll see is peripheral vasodilation, especially in the skeletal muscle beds, and some bronchodilation. The blood pressure, specifically the diastolic, might actually dip a little.
Even though the heart is starting to speed up a bit from beta-1.
Right, the vasodilation can overpower the early inotropy.
Okay, let's turn up the infusion, intermediate level.
At intermediate doses, say 0.03 to about 0.2 mics per kilo per minute, the beta-1 effects really start to take over.
So now we're talking about the heart.
Now it's all about the heart. Heart rate goes up, contractility goes way up. You are driving the cardiac engine much harder. The systolic pressure starts to rise significantly.
And then the high dose. The code blue dose.
At a high dose, anything above 0.2 mics per kilo per minute, this is where alpha-1 predominates.
The squeeze.
The squeeze takes over. The beta effects are still there, but they are buried under this massive, widespread vasoconstriction. Systemic vascular resistance, the SVR, just shoots up.
So low dose is flow or vasodilation. Intermediate is pump or cardiac output. High dose is squeeze or vasoconstriction.
That is a perfect way to summarize it.
Yeah.
You have to remember, when we give that 1 milligram bolus in a cardiac arrest, we are flooding the system. We are way, way past the beta range. What we are looking for is that massive alpha-1 vasoconstriction to clamp down the periphery and shunt whatever blood is left to the brain and the heart.
We're sacrificing the limbs to save the core.
That's exactly what we're doing.
But it makes perfect sense. Let's dig into the pharmacodynamic effects in more detail. We've touched on the heart, but let's get specific for the written paper.
Okay, cardiovascular effects. As we said, it increases heart rate, contractility, and cardiac output. But, and this is a huge but, it comes at a cost.
The oxygen cost.
A massive cost. It dramatically increases myocardial oxygen demand, the MVO2. If your patient has coronary artery disease, adrenaline is a double-edged sword. You might get their pressure up, but you might also be tipping them into a myocardial infarction.
What about the blood pressure numbers specifically? Systolic, diastolic?
It's complex, and it follows the dose dependency. Systolic pressure almost always rises because of the beta-1 inotropy, but the diastolic pressure depends on the dose. At low doses, it might actually fall because of that beta-2 vasodilation. At high doses, it will rise because of the alpha-1 constriction.
Which leads to that classic sign.
A widened pulse pressure. The gap between the systolic and diastolic numbers gets bigger.
And for the respiratory system?
Two things. The big one is potent bronchodilation via beta-2. But don't forget the alpha-1 effect on the mucosa of the airway.
Mucosal decongestion.
Exactly. It shrinks swollen tissue, which is why we use nebulized adrenaline for things like croup or post-extubation stridor.
Right. Now, the metabolic effects, I feel like this is a huge trap in the ICU.
It is a massive trap,
Yeah.
and every new resident falls into it. Adrenaline causes hyperglycemia. That's easy.
Right.
It stimulates glycogenolysis and inhibits insulin release.
But the real trap is lactate.
The real trap is lactate. We are all trained to think. High lactate means shock, bad perfusion, the patient is dying.
Right. If the lactate is going up, something is terribly wrong.
Normally, yes. But with adrenaline, it's different. Adrenaline, through its beta-2 stimulation, revs up the sodium-potassium pump in skeletal muscle. This forces the cells into accelerated aerobic glycolysis.
Aerobic, not anaerobic.
That's the key. The cells are churning out lactate even though they have plenty of oxygen. This is a type B lactic acidosis. It's a drug effect, not necessarily a sign of worsening tissue hypoxia.
So if I'm in the ICU, I've got a patient on an adrenaline infusion, and their lactate starts climbing from 2 to 5. But their blood pressure is good, their urine output is good.
Do not panic. Do not just blindly turn up the fluids or add another pressor.
You have to look at the whole clinical picture.
You have to look at the whole patient. It might just be a sign that the drug is working. Both the Oxford Handbook and ICU protocols are very clear on this point.
That is absolute gold for ward rounds. Okay, let's pivot to clinical uses. This is marked as an exam favorite.
Top of the list, no question. Cardiac arrest, ACLS guidelines. The dose is 1 milligram par fee every 3 to 5 minutes.
And the concentration is critical here.
Absolutely critical. For 5E use in an arrest, the solution is 1.10 thousand.
Okay, let's just pause there. 1.10 thousand versus 1.1 thousand. This is the classic student mistake, isn't it?
It's a classic and potentially lethal mistake. The 1.1 thousand solution contains 1 milligram and 10 milliliters of fluid. It's diluted for IV use.
Okay.
The 1.1 thousand solution contains 1 milligram in just 1 ml. It is 10 times more concentrated.
And if you give that concentrated solution IV to a patient with a pulse?
You can kill them. You will cause catastrophic hypertension, a stroke, lethal arrhythmias. It's one of the most dangerous drug errors we can make.
So 1.1 thousand is for...
It's for anaphylaxis given intramuscularly, or for nebulization, or for carefully diluting to make your own infusions. But you never, ever give a 1.1 thousand bolus Steffi.
Understood. Speaking of anaphylaxis, why is adrenaline the drug of choice there? Why not just give a powerful antihistamine?
Because antihistamines are too slow, and they only block one mediator. Anaphylaxis is a physiological collapse. You need a physiological antagonist.
And that's adrenaline.
That's adrenaline. Histamine causes vasodilation and bronchoconstriction. Adrenaline does the exact opposite.
Right.
It gives you alpha-1 vasoconstriction to fix the blood pressure and the mucosal edema, and it gives you beta-2 bronchodilation to open the airway. It attacks the problem from every angle.
What's the dose for anaphylaxis?
For an adult, it's 0.3 to 0.5 milligrams IM, intramuscular. And the best spot is the lateral thigh, the vastus lateralis, for the most rapid absorption.
We also use it in local anesthesia, the adjuvant role.
Yes, very commonly. We add it to drugs like lidocaine, usually at a 1.200 thousandths concentration.
Which is 5 micrograms per ml.
Correct. It constricts the local blood vessels. This does 3 things. It keeps the local anesthetic where you want it, prolonging the block. It reduces systemic absorption, so less toxicity, and it gives you a nice bloodless surgical field.
Fantastic. So what can go wrong? Let's talk adverse effects.
Well, we've mentioned the big ones. Cachyarrhythmias are very common. VT, VF. The hypertension can lead to a cerebral hemorrhage. Metabolically, you have the lactic acidosis and also hypokalemia.
Hypokalemia.
Yes, adrenaline drives potassium into cells, so you can get a transient but sometimes significant drop in serum potassium.
And there's that specific anesthetic interaction with halothane. It feels a bit historic, but I know exams love history.
They absolutely do. The classic teaching is that halothane sensitizes the myocardium to catecholamines.
What does that actually mean?
It means that if you're using halothane and the surgeon infiltrates the field with adrenaline, the heart is much more likely to develop a severe arrhythmia. You have to strictly limit the dose of adrenaline used.
Is that true for modern agents?
Much less so. Sevoflurane and isoflurane are far safer in this regard. But you absolutely must know the halothane interaction for the paper.
Okay, that feels like a comprehensive look at adrenaline. Let's move to part C, isoprenaline or isoproterenol. This one feels like a drug that's, well, it's fallen out of favor, but it's still so important scientifically.
It's what I call the forgotten catecholamine. But pharmacologically, it is beautiful because of its purity. It teaches you exactly what the beta receptors do in isolation.
So let's identify it. What is it?
Isoprenaline is a synthetic catecholamine, and Tripathi points out the key structural difference. It has a bulky isopropyl group on its enamine side chain.
And that bulky group is like a key that's too big to fit in the alpha lock.
That is a perfect analogy. It cannot bind to alpha receptors. So its receptor profile is
Pure beta.
pure beta, beta 1 plus beta 2 plus beta 3, zero alpha activity.
Zero alpha. And that means zero vasoconstriction.
Precisely.
Yeah.
And that single fact dictates its entire hemodynamic profile.
So walk me through it. It hits beta 1.
So it's a potent positive inotrope and chronotrope that makes the heartbeat fast and hard.
But it also hits beta 2.
So it's a potent vasodilator. It drops the SVR massively.
Okay, so what does that actually do to the blood pressure? This feels like a classic Viva question.
It is the classic Viva question for this drug. The systolic pressure might stay the same or even rise a little because the heart is pumping so much harder.
Okay.
But the diastolic pressure plummets. It just falls off a cliff because of all that beta 2 vasodilation.
And if the diastolic falls that much, the mean arterial pressure, the MAP...
The MAP almost always falls.
And this creates a really dangerous situation for the heart itself, doesn't it?
It creates what I call the perfect storm for myocardial ischemia. Think about it.
Okay.
The heart is beating faster and harder because of beta 1, so it needs much more oxygen. That's increased demand.
Right.
But at the same time, the diastolic pressure has crashed because of beta 2. And remember, the coronary arteries that feed the heart muscle fill during diastole, so the perfusion pressure is reduced.
So you're increasing demand while at the same time cutting off the supply.
Exactly. It's a recipe for disaster in a patient with coronary disease.
That sounds incredibly risky. So why on earth do we still use it? What are the clinical indications?
Well, we certainly don't use it for shock anymore. Let me be clear. Never use isoprenaline for septic shock. The vasodilation will kill the patient. Its modern niche is strictly electrical.
Electrical problems in the heart.
Exactly. Specifically, hemodynamically significant bradyarrhythmias. We use it as a chemical pacer.
A bridge to pacing.
A bridge to pacing. If you have a patient with complete heart block, their pressure is dropping, and you're waiting for the cardiologist to arrive with a transvenous pacemaker, an isoprenaline infusion can bridge that gap.
And it's also used for torsades de pointes, right?
Yes, conceptually this is important. In drug-induced torsades, where you have a long QT interval, we can use isoprenaline to overdrive pace the heart. By speeding up the heart rate, you physically shorten the QT interval and can terminate the arrhythmia.
And I see a note here from the ICU protocols about its use in heart transplants.
Yes, this is a great point. A transplanted heart is a denervated heart. The vagus nerve has been cut.
Which means atropine won't work.
Atropine does nothing because it works by blocking the vagus nerve. But the heart muscle itself still has beta receptors on the surface. So isoprenaline, which works directly on those receptors, is very effective at speeding up a slow transplanted heart.
What are the main adverse effects we need to worry about besides the ischemia?
Well, tachyarrhythmias are extremely common. It's very easy to push the heart rate too high and tip someone into VT. And hypotension. If the patient is even slightly hypovolemic, the profound vasodilation can cause a complete cardiovascular collapse.
Okay, we've done adrenaline, we've done isoprenaline. Now let's bring it all together in Part D, comparison and clinical integration.
This is where you score the really high marks.
Yeah.
You have to be able to compare and contrast them clearly.
Okay, let's do a quick fire comparison. Receptor profile.
Adrenaline, alpha and beta. Isoprenaline, beta only.
Blood pressure response.
Adrenaline is either biphasic or a sustained rise in MAP. Isoprenaline is a guaranteed fall in diastolic pressure and usually a fall in MAP.
Right.
You can think of Dale's vasomotor reversal. If you give an alpha blocker first, adrenaline starts to act just like isoprenaline. It shows you the power of that unopposed beta-2 effect.
Heart rate.
Adrenaline increases it, but if the BP shoots up too high from the alpha effect, you can sometimes see a reflex bradycardia. It's rare, but possible.
Whereas with isoprenaline,
It always causes a marked tachycardia. There's the direct beta-1 drive plus a reflex tachycardia from the hypotension. There's no alpha squeeze to oppose it.
and the main clinical niche.
Adrenaline is for the stop heart, as in cardiac arrest, or the collapsing pressure, as in anaphylaxis or shock.
Stopped or collapsing, okay.
Isoprenaline is for the slow heart, bradycardia or heart block.
That is a brilliant summary. Stopped or collapsing versus slow.
Let's apply that. Think about a patient with septic shock. Their SDR is already low. They are profoundly vasodilated.
So you would never, ever want to give isoprenaline.
Never. It would be absolutely disastrous. You need an agent with alpha squeeze to restore vascular tone. That's noradrenaline, or in refractory cases, adrenaline.
So you have to tailor the drug to the specific physiology of the shock state?
You have to. It's not one size fits all.
All right, let's cover the Viva traps. The tricky questions examiners love to ask. Trap number 1. Why don't we routinely give IV adrenaline for asthma?
That's a great one. And the answer is risk versus benefit. We do use it for life-threatening asthma, but usually nebulized or subcutaneous first.
To limit systemic side effects.
Exactly. Giving it IV carries a very high risk of dangerous tachyarrhythmias and hypertension. You only go there if the patient's about to arrest or already has.
Okay, trap number 2. Can I use isoprenaline in a patient having an MI who develops a complete heart block?
Oof, dangerous ground. As we've discussed, isoprenaline is the perfect storm for ischemia. It increases oxygen demand and drops coronary perfusion.
So it could make the heart attack bigger.
It could extend the infarct. The much safer option is immediate pacing, either transcutaneous or transvenous. Isoprenaline should only be a very temporary bridge, used with extreme caution.
And let's just hammer home the concentration mistake one last time.
Never, ever confuse 1.1 thousand with 1.n thousand. It is a lethal error. Always check the ampoule. If it's a 1 milliliter ampoule of adrenaline, you must assume it is a concentrated 1.100 solution until you prove otherwise.
Okay, now for the final part of the puzzle, presentation. Section 16 is on diagrams. You're in the exam hall. The examiner slides a piece of paper over and says, draw the effect of these drugs on blood pressure. What are you drawing?
You need to have figure 9.3 from Katie Tripathi burned into your memory. You draw 3 lines, systolic, diastolic, and mean BP.
Okay, what does it look like for isoprenaline?
For isoprenaline, you show the systolic BP staying flat or maybe rising a tiny bit. You show the diastolic BP crashing down, and you show the mean BP falling. Then separately, you'd show the heart rate shooting up.
And for adrenaline?
For adrenaline, it's more complex, but the classic pictures just show the systolic rising sharply, the diastolic dipping slightly at first, and the mean BP rising. The key feature is that the pulse pressure, the gap between systolic and diastolic, widens significantly.
And what about a signaling diagram?
You need to be able to draw the cell membrane, draw the 7-pass serpentine receptor. For a beta receptor, show the GS protein activating adenylyl cyclase, which converts ATP to KMP.
And for alpha-1?
For alpha-1, you show the GQ protein activating PLC, which splits PIP2 into IP3 and a D, leading to calcium release. If you can label those steps correctly, especially the specific G proteins, that's easy marks right there.
We are nearing the end of our dive. Let's summarize part 17, the exam conclusion.
Okay, here is your high-yield cheat sheet. Ready?
Ready.
Adrenaline. It's endogenous. It hits both alpha and beta receptors. It has that critical dose-dependent switch. It is the workhorse for CPR, anaphylaxis, and refractory shock.
Got it.
Isoprenaline. It's synthetic. It hits beta receptors only. It's a potent vasodilator and chronotrope. It is the specialized bridge for bradycardia and heart block.
And if I have to write a model conclusion paragraph for that 20-mark paper,
You'd write something like this. In conclusion, while both adrenaline and isoprenaline are potent sympathomimetics, their differing receptor affinities dictate their distinct and non-interchangeable clinical roles. Adrenaline serves as the life-saving resuscitation workhorse for restoring perfusion pressure, whereas isoprenaline functions as a specialized chronotropic agent for managing electrical instability. A thorough understanding of this distinction is fundamental to safe and effective practice in anesthesia and critical care.
I feel like I could actually write that out now without my hands shaking.
You're ready. Just remember, when you're in there drawing those graphs, be neat, be precise, and label everything.
We really hope this deep dive has helped you organize that mountain of textbooks into something more manageable.
My advice to you right now, go grab a piece of paper and draw those receptor pathways and those blood pressure graphs. Right now, while it's fresh, it helps it stick.
Good luck with all your preparation. Go crush that exam.
You've got this. Good luck.